Welcome everyone to this guest lecture organized by LSE-SU Health Society. We are very grateful to Dr. Henrique Martins for agreeing to speak to us. I've just been told, he just told me that he's in Korea and it's 1:30 a.m. there. So we are double grateful to have him here. What can I say? Dr. Martins wears many hats. He's a medical doctor, a consultant in digital health, a former president of the Shared Services and eHealth IT Authority of the Portuguese Ministry of Health, and a former co-chair of the EU eHealth network. So I'm sure he can tell you more about himself, but that just shows how interesting this talk will be. The title of the lecture, as you know, is "What Future Can We Expect Between Tech and Health?" And Dr. Martins will share his insight on digital health and AI, governance and policy implications for the future of health. So I'm really excited about this lecture. I've got personal interest in eHealth and in policy. I'm a lecturer at the LSE in Department of Management, Information Systems in Innovation Group. And my name is Klecun. And I teach eHealth course, so I hope that I will learn many interesting things today. The new technologies for healthcare have been developed for a while. AI has been talked about and under development to some extent for decades. I remember as a student of computing, learning about AI, and yet it's only now where it's really is being adopted, still in some niche places, but I believe that a huge transformation is taking place, not just because of AI, but because of other new tech. And this requires new policies and regulations, and we will hear more about it today. So this is for me very exciting area, and I hope for you too. But you haven't come to hear from me. So I will ask Hugo from LSE-SU Health Society, the president of the society, to make any further comments and invite Dr. Henrique Martins to speak to us.
Thank you a lot, Professor Ella. Good afternoon, everyone. I would like to precisely share my appreciation for Professor Henrique, that I know for some time already back in Portugal, to be with us today and to share some of his experience on this topic that at this level is always central at everything that we study, that we discuss. And so I will let Professor Henrique speak about it. We'll have 1 hour for our presentation and then some answers on your side. I'll ask you to write them on the chat, and then we'll give you opportunity to ask them later on. Thank you very much. Enjoy.
Good afternoon, everyone. Thanks for the invitation, and yeah, let me start sharing my screen. I must confess that I will cover different topics, not only AI, because AI is now embedded in many of the topics.
Mm-hmm.
So that is my first comment that I would like to say. You know, when you hear about AI, you need to think of AI as as electricity, for the new digital health tools. So, for example, and this is the example I bring today, when we think about telehealth and meta health, which is metaverse healthcare, and I will talk much more about this. This is a good example of an area which is old concepts, telehealth. Many concepts of telehealth apply in the metaverse because, of course, patients and professionals are not co-located in the same context, but they are having a caring relationship. But what is the big difference between telehealth technologies and metaverse technologies? Exactly that metaverse uses AI for most of its existence, the creation of images, the creation of movement, and different sources. So this is as an example. But I've decided to look at the digital health governance aspect. And before I start, share with you what I see are the main advanced digital health challenges. So this slide is very busy on purpose, so that's sort of a screenshot. If only you could take this home today, that would be it. We have an aging society, technology-rich society with more knowledge. We maintain our aims for a healthcare system that is equitable, safe, efficient, patient-centered, timely, and effective. As we did more than 20 years ago. This question, the Quality Charting Report, was a fundamental report more than 20 years ago. We're still not there. So as I normally say, it's very easy to, well, sometimes it's not easy, but it's easier to write a good report and a good strategy. Sometimes it takes decades, as already been mentioned by Ella, that it takes us decades to get to AI, and this has been envisioned many years ago. The same goes for telehealth and many other things like care integration concept or a GP for everyone, which we haven't achieved in almost most countries in the world, as the WHO calls it, universal health coverage. This is to give you time to read on data. We need to talk about data as the new goals, as open and fair principles, findable, accessible, interoperable, and reusable data. If information exists only when sharing purpose is there, then we are talking about content interoperability, which is now a key aspect. And of course, knowledge involves hybrid intelligence and advanced intelligence. In other sessions, I often use the word AI to talk about advanced intelligence because actually there is no artificial intelligence. There is only advanced intelligence because you need human intelligence to come up with the advanced one, at least for now. And then meta knowledge has to do with who knows who knows and what and how it knows. What are the 5 main digital health challenges right now? And this goes across the board, across the countries, UK, EU countries, here in Korea. I was just presenting some of this material early today in the Ministry of Health. And that's why I decided, let's share with the same day, not all the slides, but some of the material and let you see, what is the policy discussion. So these are the conversation that me as an expert have had on some of these topics today with one of the most technologically advanced countries in the world. And when I say digital inclusion, they also have the problem here. They have citizens that are not capable of fully using digital technology. And although we are advancing rapidly in educating citizens and we have millennium generations that are capable, we also have still elderly patients that are not. And actually, this percentage is 20 or more percent, depending on the region, the urbanity of the people, and of course, their economical status. But also, organizations. What we now see in many countries is that some hospitals are rich enough to have advanced digital technologies, and other hospitals of the same country are not as rich and are not as capable of setting up digital ecosystems that are effective. Minimally disruptive tele and meta health services. This is a big challenge, is how to offer telehealth and meta health services that offer high quality of care. And defining that quality of care or telecare is now a challenge. One of the works that I'm doing for WHO Euro is creating a toolkit, a self-assessment tool for countries across Europe, including the UK, to do what I would say a self-check, whether their telehealth ecosystem is capable of providing the highest quality of care. Then the third challenge, trustworthy digital clinical services. What are digital clinical services? These are services that include mHealth apps, what we normally call wellness apps, health apps, but also AI-based solutions from both diagnostics and therapeutics and digital therapeutics, which may include AI or not. Often they do. Now, how do you trust these systems? Not just the patient, but also the professionals that prescribe these digital clinical services. Fourth area, health data economy and health innovation. When we talk about health data spaces, this is a big topic right now in the EU, but not only. Over here, for example, in Korea, there's a new law in the parliament to be discussed on data exploration. And over here, for example, they're talking about creating a non-for-profit foundation for data exploration that brings together all research hospitals across the country and companies and innovators. So a different model from the EU, maybe a different model from the UK. But in any case, the two topics are there: data economy, getting value out of data, and health innovation, finding new drugs, new diseases, new procedures to care for new diseases. And then very fundamental, digital sovereignty and sustainability. I was last week as part of a project where I collaborate with Ukraine, Moldova, Uzbekistan, in Georgia, and the presentation from the Ukrainian eHealth responsible was incredible. They did not switch down their systems, or they actually reinforced their digital transition. They did a lot of investment in telehealth, and they are now super resilient, because every day they are cyber attacked by Russia. But yet they do not quit. They do not turn off the systems, except when a hospital is invaded, they turn off that hospital down so that the other hospitals are protected. So it's an incredible example of how digital health survives and actually thrives in the war. When you think about health and surgery, for example, wars have been instrumental in developing surgery over the centuries. And, here's a good example, well, for the worst possible reasons, but anyway, we can learn from that. So what do I want you to focus today? Digital health governance, leadership, and accountability. And then developing a national strategy and looking at sub-strategies, one of which AI health, definitely. Now, when I was leading the digital agency in Portugal, we tried and we did achieve this logic of having a national document that is overarching, and then sub-strategies. Telehealth was one of them. We had another one on secondary use of data, including AI. And this is very important. Why? Because so many challenges. How can policymakers survive? Well, the only way is really to have it written down. It's according to me. But this is not the truth in all countries. Not all countries have a digital health strategy, but many do, and many are working on this. And why? Because having a strategy is perhaps the most important governance instrument, because it allows you to clearly define who is leading, who is following, and where's the accountability model. So if you are discussing these topics in your course on policy and governance, it's fundamental to define not just who governs what, but how. And that's where the strategy kicks in. Now, what are the instruments? Well, there's two types of instruments, in a nutshell: legal and regulatory, and architectural systems, so IT architectural. Now, I don't have the time today to cover the last two in detail, just enough to say that sometimes you even need a law to mandate someone to do a national strategy. For example, in the case of Portugal in 2015, this is what we got. We got a mandate from the Council of Ministers to outline a draft, so somehow very high-level strategy, which was then divided and detailed. So very quickly on governance of digital health, which, of course, has to do with processes, structure, and stakeholders. It is crucial for effective leadership. Why? Because you need to steer and coordinate between all relevant entities. And one of the things that is more fascinating on digital health is the incredible amount of entities that are related. So it's everyone from the health sector, It's everyone from the digital sector. It's everyone from the educational sector. You cannot conceive of a good digital health strategy without thinking of universities. And what do? They research on digital health, they teach on digital health, they prepare teachers to use digital tools, they prepare doctors to use digital tools to doctor, and so on and so forth. So it's an incredible ecosystem of stakeholders that has to have some sort of governance structure. And what is governance? It is defining sustainability, transparency, aligning investment decisions, and meeting health system goals. And if you can do these 4 things, then you're good. Well, at least you're not too bad. Now, what are some good governance principles? Having good processes, having good structures, and having stakeholders involved. And of course, I don't want to go into all of the detail in this slide because it would take us the 40 minutes that I have. But as you can imagine, for example, stakeholders, mapping them, exhaustive map of stakeholders, going round and round and see, oh, did we forget anyone? And suddenly you forget that there are hospitals in prison hospitals. And you have to involve the Ministry of Justice because they're the ones running the hospital prisons. And hospital prisons have e-prescription. And hospital prisons have electronic health records. And hospital systems need to do a lot of telehealth so that the prisoners don't have to move out of the prison. So suddenly you think, oh, okay, well, I forgot these ones. But why are hospital prisons different from other hospitals? Can you understand the stakeholder? Well, actually, they are. They're very different. For start, the type of diseases are different. Percentage of cases is slightly different. The access people have to certain things is different, and so on. This is just one example out of a very interesting project at some point in time in our government in Portugal, where the Minister of Justice met our Minister of Health, and they got together. They got along very well, and they got together and they said, you know what? We need your help on the digital. And they said, okay, I'll call the head of the agency. And I got this phone call. You know what? I'm going to celebrate this protocol with the Minister of Justice. We're going to help them boost up their digital technologies in hospitals. The first time I went to a prison hospital, I can tell you, I was shocked. At least in Portugal, I was shocked. And I was shocked because it was about 10 years behind of time compared with any other hospital of the public sector in terms of digital health. And paradoxically, you want that information. You actually want that information very badly to manage these patients, because the level of disease in prison population is higher than the level of disease in non-prison population. This is just an example of why do you do digital health, which is something many students don't know how to answer. If I was doing the essay, my question for your essays would be, why do you need digital health? Why? Not how or when or, what is so exciting about it. It's why do we need it? So trying to answer that one is fundamental on governance. So let's moving quickly, developing terms of reference. So it's fundamental before you actually start the process of governance building that you define some terms of reference. Define and identify a chairperson with long-term experience. You need a person, you need a name, a head that could pull this off. I am of the opinion that committees without the head, the strong head, normally don't get very far. And then, of course, balance, and map stakeholders, enabling secretariat to do things. I mean, these are a list of stakeholders. Don't forget non-health sector relevant stakeholders, like, for example, industry, not necessarily only IT industry, but the industries behind IT. And COVID showed us that because of chain disruption, we stopped having enough computers. And then, of course, an enabling secretariat that facilitates work, reacts, reports on progress, and so on, and evaluate governance. Something that is rarely done in the world, which is to evaluate the governance authorities. So did they govern well? Did stakeholders feel participated? Did people feel there was a direction? Were targets met? And if they were not met, what did the governance authority did. So these are just some ideas on this. Let's move on. More structured, less structured, more dynamic, more open. Well, that depends on the style, on the culture, and on the society. You cannot go with a super open model to a very traditional society. It won't work very well. Let's jump this one because I've already mentioned. So establishing an oversight function, mechanism for public engagement, a guardian function if something is not going well. There has to be a way to tell that this is not going well, and regulatory authorities as independent, process-focused auditors. Now, one of the instruments to rule is law. It's not the only one. I always say this to my students, and law is not only the law you make in parliament. It's also soft law, which you make as guidelines. For example, ONC, Office of National Coordinator in the US, which is a very important influencer of digital health in the US. But GMC, General Medical Council in the UK, if they have a digital health working group, they can become a very important soft lawmaker. So it is not the case that all law for digital health has to be going through parliament. That's actually not even true. These are the 10 pillars of what is sort of basic legislation. This is the basic that any country has to have. And if you read it, you will see that even though it's the basic list, liabilities posed by overriding clinical decision support warnings and alerts doesn't exist in most countries. What is this? It is if a doctor or a nurse decides to override a clinical decision support system that tells him or her, you know what, this patient may have this thing. And he says, oh, no, I don't believe it. That's an AI system. I have natural eye. And this is just AI. I have natural intelligence, and I don't think this is the case. My experience tells me this is not a lung nodule. So off he goes and ignores the alert. Turns out the patient did have a lung nodule and dies of cancer, which could otherwise have been resected. Now, whose fault is this? Is it the boss that doesn't force this person to follow what the IT system tells him? Is it the IT system that was not compelling enough to show him that the system was right? Where does the liability stay? It's not defined in most jurisdictions. One of the works that I have done recently as master student in public law was my thesis on AI liability in public hospitals in Portugal. The reason I'm saying it is because you're studying, you should continue to study. This was when I was 42, so you should continue to study. Off you go, finish this course and do another one, another master, another PhD, and don't stop studying. Anyway, if you don't stop, you go to advanced. And what is advanced legislation right now? We are talking about secondary use of data, definitely features on advanced approaches to legislation. Data altruism and data donation schemas. So how do people donate their data for research and even for economic profit? Data privacy mechanisms, and one of the most hot topics right now on data privacy is dynamic consent. It's the capacity of patients to give and retreat consent during the day, the middle of the day. Funny enough, when we set our national strategy, national platform in Portugal, for sharing data across the public sector, we created a dynamic consent that is just a turn of a button that you can put in and out throughout the day. And this was 12 years ago. So this is possible technically. Question is that, of course, we are now talking about privacy mechanisms that go to the level of data. I share this data, I don't share that data. For example, if I go to a hospital and I don't want to share my, sexual life-related information, but I'm okay to share my other information. So, how do you manage these subtleties of data, which you can technologically, but it is complex. And then use of AI, advanced analytics, and robotics in health services and research, and personal liability. These are some of the areas. Another thing that I think is going to be the future is the exploration of self-regulatory strategies. So self-regulation as a mechanism of regulating, especially industry development and innovation, is quite important. Now, finally, strategy. As I said, I'm not going to give you a masterclass on strategy, just highlight one or two ideas. Like any strategy, as is strategic development implementation. Now, what do you have to consider when thinking about digital health? Well, of course, setting up a vision and guiding principles. And this means engaging people, negotiating, sense making, and then strategic framework, having a logic, and then an implementation plan. I'm going to give you an example. You don't have too much time, but I'm going to give you an example so that you feel what this could be, and then we're going to look at this into metaverse and telehealth as an example. So if you are thinking about a national level digital health strategy, you need to take into account data usage, cybersecurity, digital health architecture, governance, financing and operational models, enabling legislation, the basic one and the advanced one, and of course, focus on real life use. Many digital health strategies do not solve any health system challenge because when they are writing down the strategy, they are writing them from the digital to the health, from the health to the digital. And you should write the strategy thinking of health. So what do you want to change in the healthcare system? And why do you want to change it? And then why do you need to use digital? And then how do you need to use it? So if one of the problems of Korean society, Norwegian society, I guess also UK society is mental health problem, tremendous problem. We are not solving it. It's getting worse every year. We're putting millions of euros, millions of pounds, millions of dollars, whatever you want, and it's not getting better. Now, then we have to focus on that and say, okay, mental health, we want to have at least the same indicators as we had 10 years ago. It's like a carbon, you know, at least stop getting worse. And then try to understand why people are not happy, why people are not okay, why people are not, are not feeling so happy and so good. Now, digital can help. How can it help? Well, one of the first things that it can help, for example, in mental health, is mapping the problem, mapping the circumstances where there was the problem. And also, of course, therapeutics and many, many, many other solutions. Anyway, very old referential, that is a sort of a classic. So you should always use a classic when you're doing work, which is National eHealth Strategy Toolkit from WHO. Very old, but still useful. And then some tips, you know, no more than 5-6 objectives, a 3 to 5 year period. Well, this depends on the country and the style of planning that each country has. A line to address the greatest burdens of disease, as I have said, very important. And then things to consider. Well, consider ministerial level oversight, strategic financial costing and implementation plans. Of course, digital health ecosystem, you know, as it develops, and specific groups may also develop domain-specific digital strategies. So assume it is an evolving strategy and that it is constituted by sub-strategies. This is an example from the telehealth strategy from Portugal, 2018. We looked at what we called at the time telehealth implementation cycle. So we come with a framework to organize ideas. Okay, what is a framework? Is a way to think and not forget anything while you're thinking. So many times people start thinking and then they forget what to think. That's why you should do a framework, right? It's like SWOT analysis. You do a 4-square diagram in a paper and you try not to forget to fill in the 4 parts of the paper. Because if you started without the framework, you often would forget something. So we came up with this idea that to do telehealth, you need to design and contract and finance it. You may need to define or redefine regulation. And this means hard law, ministerial orders, or professional deontological codes. You may need to reorganize care delivery, setting up clinical governance and adjust the workforce and clinical guidelines, and then deploy infrastructure, adapt information systems, and incorporate innovation. Now, why am I giving you this so clear example? Because a strategy is not something from rocket science. It is a normal thing. It is, how do you go from A to B? So how do you go from not having telehealth to an innovative telehealth ecosystem? And these are the 7 steps. Well, this is what I thought in 2018. And then I was invited by Slovenia later, 2021, to design the national telehealth strategy, national strategy for digital health, but also within that, a telehealth framework. So I looked at the model and I realized that there was a few things missing, like audit and quality assurance before innovation. So you can't really innovate without auditing. You cannot improve without measuring. So that was missing there. Governance, oversight of the entire process, and ethics, privacy, and security principles in and adapted to telehealth. So we come up with 10 blocks, and this is the structure of the general digital health framework. So six blocks: governance, legislation, financing, workforce, IT services. And then when you map the telehealth sub-strategy to the general strategy, you see the color code, and you see that some things fall under governance, some things fall under legislation, some things fall under services, and reorganizing care falls under workforce and service. So how does this work? Once you have the framework, you then look at the country and you start to say, okay, here's the financing authorities. This is not a mistake. This is really the name of the entity. It's 3 Z's and an S. And okay, how are we going to use hard law and soft law and so on? So this was the work done with them, and ending with the suggestion of a national telehealth center, organized as a distributed center. It's not a one organization. It's distributed across different organizations. It's the concept of a network node organization construct. And now, as an example of the work that I'm doing here in Korea, so as a visiting professor here, I am drafting the Meta Health Korea, which is a tele and meta health strategy for South Korea. And of course, I started with the concept. What are the patients like? And patients are going to change. Patients are progressively connected, sometimes for life. Brain connections. I saw that Diogo just joined our meeting, and he just submitted a paper that he was the main author on brain-computer interfaces. Congratulations for him. But why is this relevant? Because AI is going into the brains of people. When you connect brains through electrodes, and then you process the signals through AI, brains are being connected with AI as we speak. And this is both scary and exciting. And as a digital health freak, I'm both excited and scared. So when I was a doctor, I was interested in digital. When I did my management and PhD in Cambridge, in the UK, I wanted a lot of digital very fast. I wanted to put it. And then a few years later, I started putting it everywhere in my country. And then I ended up reading law and reading that sometimes you need to make a break and see whether it makes sense or not to do it. So over time, I sort of moved to another position. But actually, and this is just to make you interested, digital is literally going into the human body and into the human brain, okay, and into the human mind. And actually, after the human mind, as we call post-humans, when we build avatars to have life in a metaverse, on a meta clinic, when we create our own avatar as a teenager, and we go to a meta clinic for child, pediatric, adolescent psychology and psychiatry, we are creating what we call in academic literature post-humans and artificial lives. And this is very exciting because these people that have an avatar can often benefit from therapeutics that they wouldn't receive, either because they cannot move physically or they are so afraid to expose themselves physically that they would prefer to have a digital representation of themselves while they are in a healing process. Concepts, telehealth, telemedicine, well, there's many different definitions. I'm not going to bother you with that, but it's sort of obvious that telehealth is broader than telemedicine, and eHealth is even broader. Synchronous, asynchronous, and so on. Trying to clarify concepts is very important when you define governance and strategy. One of the most important things to avoid conflict with stakeholders is definition. Because if the definitions are not clear, stakeholders, they don't understand each other, they don't understand what you're talking about. If everyone understands telemedicine to be only teleconsultations, they don't see the value of telemonitoring. They don't understand teletraining, the usage of tele-education in large underserved societies and communities is very important. And no one will challenge that. If you don't know what the metaverse is, this is the single best paper to read. 380 references, and the authors are not humble. They label their paper with the following title: All One Needs to Know About the Metaverse. So, that's true, actually. It's a brilliant paper. And it's brilliant because it talks about this reality as both a technological reality and an ecosystem sociological reality. They go all the way to talk about social acceptability, privacy, trust, and accountability. So it's worth reading for sure. It needs duality. So whenever you talk about metaverse, never forget you need to create your own representation of the patient, of the professional, of the process, even the infrastructures, recreating a hospital in the metaverse. 4 types of metaverse. And why am I showing you this? I'm going to go quick. It's because you need a model. In this case, this is work that I have done with other colleagues. You see the other authors there, and Juan, Catherine, and Giovanna. Anne is a nurse, Catherine is an engineer, I am a doctor, and Giovanna is a pharmacist. And together we wrote this small paper called Personal Health Data Space. And this is the construct of how should we organize health data around the person, to the point that visualization is possible and analytics. And it is at this point that health data about me helps me create my avatar, my virtualization of the patient, of the professional, or the organization. And it is at this level that we can interact in terms of mental health. If we are talking about access to data, curate the data, and control the data, then we want mHealth solutions so that I can give dynamic consent everywhere. Coming up from mHealth to telehealth to metaverse is a continuum. Of course, these are different concepts, different experiences, but it's growing and becoming more connected. Now, why do you need all of these concepts? Create a sub-strategy and to conclude my talk. Because if you didn't have the concepts right, you don't know where to focus the strategy. In this case, what I'm suggesting here is that the strategy focuses on meta health, which is health promotion, disease prevention, and care provision using metaverse or metaverse-related technologies. In some ways, these are forms of health, sometimes they're not. Metaverse healthcare, which is the use of metaverse for the improving of health systems. Seems the same, but it's not, because it includes education, planning, simulation, facility enhancement, administrative services. And finally, societal metaverse. So when you think about societal metaverse, you can design it to be helpful for healthcare or not. It can be harmful for health. So it's how do you design a metaverse experience that actually does not do harm? A very golden rule of health: first, do no harm. Now, any strategy on metaverse will need to be divided into the 3 to 4 types of metaverse. So it's dividing the strategy into the technology components, always important. And then, we're looking at, in this particular country, industrial capacity, societal attitude. So these are the aspects that you want to strategize about. So conclusion, vision, leapfrog in telehealth usage, be the industry leader on metaverse. This is my proposal. For example, for this country, which is Korea, hybridization of care and industrial partnerships as guiding principles. And then implementation framework adopted, which adapts to the 4 types of metaverse, and then some implementation plan ideas that is still very preliminary. And this is the work that I'm doing, is trying to apply the model and see, okay, can I fit the different topics into this model? Do I need to change the model? And that's it. Over to you for questions, comments, anything you want to say. You have exactly 15 minutes and then 1 minute for goodbye.
Thank you very much. We had one question from Sandra Cruz. Would you like to ask it, Sandra? I don't know if you can hear me. So it was asking about a real example of mapping and how it was solved. And I wanted to add to it. I was wondering if you could tell us examples. You talked about strategy for metaverse. Have you seen already implementations beyond sort of trials of this?
Yeah.
And could you give us some examples, please?
Okay, so let me address Sandra's question. I think she's talking about mapping of the stakeholders. So, for example, in the Portuguese NHS 2022 strategy, the document includes the mapping of stakeholders. I can, go online and the PDF is online. But if you write on Google something like this, you will find this. And there's a PDF document both in Portuguese and in English, if I'm not mistaken. Just write that in PDF. And so mapping stakeholders is not a very exciting methodology. You just start with a first list and then you ask them to think, do you have any relationship with these other people? Are there any people that you need to help or that can help you? And so on. And that's how you do it. So, for example, you think, okay, what are all healthcare provider institutions? I'll give you this example. Many people forget gyms. They assume that a gymnasium is not a health provider institution, but actually, many gyms have healthcare professionals. Now, okay, so then you add the gyms, but you're not going to call them health care facilities. They are wellness facilities. Okay, if they are wellness facilities, what about a restaurant that is so specialized in healthy food, it is concerned with people about nutrition and so on? Is that restaurant a health care institution? No. Is it a wellness institution? Yes. So suddenly, are all the restaurants a wellness institution? No. So suddenly you have to draw the line and define, okay, what is a wellness institution for the purposes of this particular strategy? And why is this important? You want to capture all the calories that the person is consuming and burning. And so you want to connect the machines from the gym to a personal health data space calculator that includes all the running and sweating that you've done in the gym in the morning. But then when you go to the pastry shop and you put your NHF your fiscal number in your bill, it includes the calories of the cake. So not just the pounds, how many pounds it cost you, 1 pound, 2 pounds, but also that it had 120 calories. And this is a legislation issue. I could force that restaurants not only put the value of the money in the bill, but they can put an approximation of calories and fat. Now, if that happens, then I can connect the IT system of the restaurant to the IT system of the healthcare environment. And this is what we are now calling exposome. Exposome is the word to talk about the environment to which we are. And you know, how much should we collect of all this data? Well, there's two answers. All there is to collect that is relevant for health, which is pretty much everything, because you never know. But you also don't want to be connecting every little piece of everyone to the health ministry. So it's a balance. So mapping the stakeholders is a never-ending exercise. You will need to draw the line and say, okay, for the purposes of this strategy, these are the most important. Now, addressing your second question, Ella, metaverse. Yeah, I mean, one of my first adventures here, for example, in Korea, in January, that it was very cold. And I had a lot of meetings with people that say they are doing things exactly to try to see. I did the same in Singapore and so on. So what is there in terms of real world educational experiences? So training of professionals using metaverse is now a reality. Medical schools in different countries are using that. So they use a metaverse created environment, or maybe it's not a full immersive environment, it's virtual reality or augmented reality, but it's happening and it's starting to happen. For care processes, they are now small projects that are no longer just research, they're startups using, for example, virtual reality and augmented reality, mostly virtual reality experiences for pain control. Where we have seen, and there are some papers already coming out, where patients with chronic pain that are exposed to half an hour, 1 hour treatments of virtual reality environments, they sort of relax, they feel less pain, and it sort of helps manage chronic pain, for example. So this is starting, but one of the biggest barriers is because there's a lot of doubts on regulation, people are a little bit afraid of investing. So there's problems with investors on these startups. And there's also problems of moving from research to clinical practice, to general clinical adoption. A little bit much like the neuro technologies. We looked at this, Diogo looked at this topic with me. And what we find out is there's pretty fascinating research, but then it doesn't hit the ground because people are afraid of legal. We need what we call regulatory sandboxes. Regulatory sandbox is the opening of an exception in your regulatory framework so that people can experiment with a technology which is not yet very mature. And this is now a hot topic in many countries, how to create a regulatory sandbox. Any more questions, anyone?
Martin, I have a question. So I'm curious about the role of AI in primary care. And the import of my question is, if you look at countries like US, the majority of people don't have access to quality primary care because of high insurance costs. So what they're doing is, in absence of primary care, they show up at the ER, and that breaks the cost economics of the healthcare system. So my question is, would you consider a paradigm where an AI doctor is completely substituting the primary care? And would you consider, again, a regulatory framework where the liabilities can be underwritten by the society to make it viable?
Well, let's say it this way. If the GP is a bad one and he only does clinical reasoning, so I'm being very careful with the words. So if he's bad because he only does clinical reasoning, he should be substituted by AI, because AI in the next few years will be much better than any human making reasoning decisions. Now, the problem is, well, it's not a problem, it's an opportunity for GPs, that humans do not go to GPs or even the emergency rooms just for clinical decisions that are rational. They go for human touch, they go for advice that is emotional, and they go for persuasion, which is a different thing from information. To persuade someone is to inform and influence at the same time. So these things, I don't think will be so easily replaceable by AI. Actually, I don't think they will be replaceable by AI, maybe by EI, emotional intelligence, AE, artificial emotional. And some people are working on that in sort of detection of emotion, but that's a different topic. So what I'm trying to say is that bad GPs should be replaced by AI. If being a bad GP is making just a bunch of decisions that any good algorithm that has a learning capability out of millions of interactions per day could do. Now, should this work be divided? Yes. I think, especially in countries like the UK or Portugal, Spain, that have a GP-based system that is unsustainable, at least in Portugal. No one wants to be a GP anymore. Costs of giving money to GPs just to make them happy doesn't work. You know, we're paying 6,000, 7,000, 8,000. They still don't want to be a GP. And so what do we need to do? We need to offload the work. All the work that GP does that AI can do should be immediately shifted for a GP service. That is an AI-based GP service. And then the remaining of the effort should focus on human-to-human interaction at a distance, ideally, or face-to-face if needed. So yeah, the answer to your question is, do I believe in that paradigm? Yes, many years ago, 2020, I wrote a small paper. It's called Digital Health Care Systems, where I start by saying exactly that there will be, either doctors want it or not, a tremendous change of paradigm. And the reason for that is that, look at the UK with Babylon. I mean, the Babylon company started off saying, we will be a solution for those humans in the UK that do not necessarily want to go to their GP. They didn't say they want to replace the GP. They just said that, you know, GPs are not available in the middle of the night, and Babylon can be. So it's about availability also and convenience. So for countries like not just the US, but for countries like India, and China, and Bangladesh, and many others, there's just no way you're going to plant millions of GPs around the world. The model that, for example, has been a successful model in the UK cannot be exported to all the countries. And even WHO, when talking about universal health coverage, is finally considering that at the end of the day, the question is, do people get the advice they need in the moment they need? Now, how that advice is delivered, is it through a human, through a machine? Is it through a health booth where you go make your labs and, you know, send the data over to the cloud and then get a pill that drops from the box? You know, whatever works. This is always my opinion. You know, I'm a pragmatician. Now, final answer, humans. Some people say AI will make the doctors more humans, exactly because they're going to get rid of all the boring stuff of thinking. Now, are doctors being trained like that? No, they're being trained to know their anatomy by heart. It's still a little bit better now, but, you know, 20 years ago, we're still like that. They're being trained to know facts. We did an experiment in my medical school last, I think this was February this year. You know, it was the ChatGPT fever was just starting. And one of my assistants, he gave a class where, you know, all students were using ChatGPT, and in the middle of the class, they were very excited. And towards the end, they were crying. Some of them were crying. And he asked, why are you crying? And they said, in the 5th year, this thing answers better than we do. And we studied 5 years. What is going to be of us? And you know, and we use this to say, you know, yeah, well, that's true. So let's move on and do what we need to do, which is to change the medical paradigm, but also the medical education paradigm. With those two changes, definitely we will have humans using all these, you know, digital tools and delivering the tools in a mix, a little bit like fusion food, in the right mix. In the right mix, I think humans still are needed to do the right mix of the technology bundle. Final question.
Okay, thank you, Professor. So yeah, let's try to wrap it up really quickly. Let me, because since you approach so many things, like so many questions could be raised after this, but I'll try to be quick and say just that you express and at least did the diagnosis really well when saying that we need to, or at least we need the digital expertise to be there from the start and to have as much as a right and duty on the architecture design of the system at the health one, but the social one too. And here then the question it raises that then everyone talks about digital health. We see all these options, but then to convince people to change the status quo, then we see huge resistance. And that's why we see so many years to implement a lot of things that we've been talking for a while. So my question becomes, where or can we point who and how to lead this construction, or is this leadership informal, made by networks of institutions and organizations that need to align but need to follow someone? Thank you very much.
Yeah, that's a very good question. You know, how much of these efforts can be led from the top and how much can be led from the bottom? I think, you know, as years go by, I've seen different models, different countries. You know, I'm a classic in that regard. I'm actually quite liberal and very not classic, but I'm a classic on one thing, which is the role of government. I mean, for God's sake, we pay people to be governed for some reason, you know, and they should govern. You know, and governing is making strategies, making decisions, making governance. Now, what sometimes society may be failing to do is to tell those that are to govern them that this topic has become important enough to deserve their highest attention. And I think my experience have told me over the years that health sector, it's almost always the same people getting attention. It's the guys from public health, because they have access to the ministers. They often become secretaries of state or ministers, blah, blah, blah. So there's a sort of a hierarchy of importance. Yeah, when I worked at the ministry, I remember, you know, the drug agency president was always, you know, always got more attention from the minister than the guys from the public health department and the guys from the digital department, you know, and you need to change this paradigm. And the reason you need to change the paradigm is because we live in digital societies, and we live in so we don't live in medicated societies, or at least we don't want to. So if the society we want for our children is not a society where everyone is taking a pill, then maybe you need to pay a little bit more attention and more budget to your digital agency rather than your medicines agency. Look at the example of the Europe. EMA, you know, the big discussion of EMA moving from London to the EU, and 1,000 staff. Where is the digital agency for Europe? Digital health agency? It doesn't exist. Not even one single person. You know, there's some people in the commission that work in this area, but as a self-standing agency, we have had regulator thinking strategy for medicines over 40 years. In digital health, we are now having one regulation, finally. So bringing awareness of the importance, but also of the solutions. So when Ella was asking, oh, concrete cases, definitely, one of the things that is really needed from even students in schools is to, write case studies, write case reports, go and search for evidence. There is very little evidence on consolidated evidence on the value of digital health, because people get so excited doing it, they think it's worth doing. But actually, they need to stop and measure and see, was it worth doing it or not? And evaluation of digital health models are very, very painful academic work. Many people do not like it, but it's very important. So this was a good session, to kickstart that type of discussion. So, thanks for organizing these things, and I think that's good.
Thank you very much. I have so many questions, but I'm not going to ask them because you have touched on so many different things. So we could discuss again, the boundaries between regulation and self-regulation, or innovation versus governance, and then data sharing and privacy, and now evaluation. It's just so fascinating. But I think we have to leave it at this. So I just want to say thank you very, very much. And this is recorded, and I'm sure more people will look at it, and I certainly will as well. So, and hopefully, if you've got any questions, if you want to discuss anything in the future, I would be very happy to have a conversation with you.
Definitely.
So,
let's keep the conversation going. Thank you so much.
and thank you, Hugo, for organizing it. Thank you for presenting.
Thank you very much.